with Dr. Anushree Naidu's talk on OCT angiography analysis beyond its retinal biomarkers. Dr. Anushree.
Good afternoon, everyone. I would be discussing in brief about OCT angiography, its artifacts, retinal biomarkers that are already described in OCT angiography, the novel methods of analysis and biomarker-free diagnostics. It is a non-invasive, high-resolution, depth-resolved imaging modality analogous to ultrasound. It provides high-contrast imaging of retinal and choroidal vasculature that are amenable to quantification. It offers the capability to identify and characterize biomarkers important for clinical practice and therapeutic research. There are mainly time domain and Fourier domain systems that help. The Fourier domain systems are more helpful as the speed of acquisition of image is very high. The SSOCT and SGOCT are the two types of FDOCT which are useful in performing OCT angiography. In SGOCT, basically a broadband light source transmits the light to the beam splitter, which then splits the light to the reference part and the sample, that is our patient, and which is then transmitted to the spectrometer, which creates a interference pattern, and it is then Fourier transformed. In SSOCT, a frequency swept light source is used, and the similar methodology is used, except for the fact that in the end there is a detector which detects and transmits the image and creates a Fourier transform. The various wavelengths used in OCT angiography are 840 nanometer and 1050 nanometer. The high wavelength gives better beam penetration and axial resolution, and it is not visible to the patient, hence motion artifacts are less with high. The various algorithms used for OCT angiography are full spectrum and split spectrum. There is a Doppler shift algorithm. It uses blood flow induced phase difference between adjacent A scan to calculate the Doppler frequency shift as the contrast between the blood vessel and static tissue. It is not well suited for choroidal and retinal microvasculature as the blood vessels are perpendicular to the OCT beam. Then the next is speckle variance. In speckle variance, the OCT signal acquired as a result of partially coherently backscattered light from biological tissue. Due to the presence of moving particles in the biological tissue such as red blood cells, the speckle pattern varies with time and can be quantified by speckle variance calculations using either interframe or interline comparisons. This is an example of image obtained by speckle variance. The split spectrum amplitude decorrelation angiography basically decorrelates the image into the 11 pairs of low resolution OCT amplitudes. The 11 decorrelation frames and then create an average decorrelation. Other algorithms used are phase variance and OMAG and SSAPAG used to create the phase variance. The various artifacts in OCT angiography are pupil viginating artifacts, defocus, motion artifacts, shadow artifacts, projection artifacts, and artifacts from segmentation. Pupil viginating artifacts means the artifacts created from the edge of the pupil as a result of low reflectance. The defocus to small vessels will appear blurred, reduced flow signals, dim structural OCT image, low strength signal strength, astigmatism, higher order aberration, and dry eye can cause same problem. Motion artifact it is caused by the eye movement. Fast motion can leave residual artifactual flow. Signal specifically on the bright structures like RPE appears as 2 to 3 bright lines on NFAS OCT. Large microsaccades appear as disjointed blood vessels, and blinking dark line appears on NFAS as OCTA. The shadow artifact flow signal is dependent on the reflectance signal from which it is derived. If OCT beam is blocked by the retinal structures or opacity in the media, there will be dark regions on both OCT and OCTA. Causes of focal shadowing are large blood vessels, vitreous opacities, hemorrhage, drusen's, hard exudates, and RPE detachment. RPE defect causes focal brightening of the reflectance and flow signal. Correlating with NFAS and structural OCT helps identifying shadowing. Shadow artifact is seen in this image. The purple area show areas of normal perfusion, green shows areas of hypoperfusion by the disease, and blue as the area of hypoperfusion caused by shadowing. The NFAS image shows the shadowing as a result of vitreous opacity. The red arrows are suggestive of intraretinal fluid as a cause of shadow artifact. The projection artifact, moving blood cast, flicker, shadow that are interpreted as flow on OCTA and appear bright. These artifacts can be visualized on both cross-sectional and en-face OCT angiograms. On en-face, there is a replication of superficial vasculature on deep vasculature. Examination of en-face OCTA slab of superficial and deep layers together help in identifying these artifacts. This is a demonstration of projection artifact. As we can see, the superficial plexus will project an artifact to the deep plexus, and image sees a better delineation of the neovascularization after removal of segmentation artifact. The artifacts from segmentation pathologies that distort retinal layers can cause errors in automated computer segmentation. These artifacts can be identified using assessment of cross-sectional scan with segmentation overlaid on structural OCT. Manual collection of these poor segmentation can resolve these errors. The retinal biomarkers that are identified on OCT image are perfusion, foveal avascular zone metrics, neovascularization, and vasculopathies. The perfusion includes vessel density qualitative analysis, non-perfusion areas, and choriocapillaries flow deficits. As we can see, the vessel density maps in the eye. The top row projection resolved angiogram of the superficial vascular complex, intermediate and deep vascular complex, and in second row corresponding vessel density heat maps are prepared. These vessel density heat maps reveal low vessel density in the area of capillary dropout. The non-perfusion areas are detected using deep learning. This is an image of CRO. I will skip this. Choriocapillaries flow deficits are identified on OCTA. Foveal vascular zone metrics assessing perfusion loss near foveal vascular zone using baseline FAZ region determined from retinal thickness, 3D parafoveal avascular vessels density in the eyes of the healthy control, diabetics without retinopathy, mild to moderate NPDR and PDR images. The neovascularization include macular neovascularization and retinal neovascularization. This is an image showing macular neovascularization. Other vasculopathies are collaterals and microaneurysms. The need for novel methods is lack of standardization of data collection and transparent analysis method, the absence of standardized image grading, interpretation methods, and metric. The novel methods are quantitative microvascular parameters, functional OCTA analysis, deep learning for vessel segmentation, multimodal imaging. The quantitative microvascular parameters include perfusion density and vessel density calculation. Calculating parameters like vessel tortuosity, fractal diameter, and capillary network. I would skip this quickly. Deep learning for vessel segmentation using convoluted neural networks to automatically segment vessels in OCTA potentially improves accuracy and reducing the manual analysis time. Advanced segmentation techniques like UNet architectures help identify complex vascular structures in challenging conditions. OCT seg and MATLABs are used for these purposes. And there's an open toolbox, Octava, which helps us analyze the OCTA images in detail. The functional OCTA analysis and multimodal integrating image integration helps combining OCTA with structural OCT to analyze the relationship. The biomarker-free diagnostics is used by advanced algorithms, and INUC is the first example of automated imaging. Thank you.
Anybody would like to ask any questions? Dr. Ajay? Very good presentation, and I think she has. Thank you so much.